Good morning, and my regards to all my seniors, my colleagues, and lots of best wishes to all the young generation that I can see here. I've traveled with the Department of Anesthesia in this college for the last 40 years. And right from that boiled trolley with halothane and ether and all those things, to these wonky workstations, which most of it I don't understand. Definitely anesthesia has gone into outer space by making it so comfortable that those wretches post-operatively and those difficult times, we don't see that. And now, virtually like all subspecialties, every organ will have their own anesthetist. And I'm sure it's not far when we'll have an ophthalmic anesthetist also. I really appreciate the way a specialty grows. And in the growing of any specialty, there are two very important factors. One is the person who steers that department. And thankfully, the anesthesia department has very dynamic people on its head. And the second is the whole team. And the team is not only till the faculty, the team is the residents, and the team is the anesthesia technicians, who are very often not spoken of. They form an integral part of the services that are rendered, because any machine is only as good as the man behind the machine. So with the advancement of science, with the diversification of the subject, I sincerely feel that as anesthetists, you all should also take up the cause of the technicians. Develop your own technicians, your cardiac technicians, your hepatic technicians, your cardiac technicians, your neurotechnicians. Just as you have a neuroanesthetist, you should also have a neuroanesthetist technician. I don't know whether they exist or not, but that would be a very positive way of moving forward. Just a food for thought. And with that, I once again wish all of you a great Foundation Day celebration, a great time to think and plan your next year, and best wishes. Thank you.
Thank you so much, ma'am, for your inspiring words to all of us. In the spirit of gratitude and admiration, let's extend our warmest regards and sincere appreciation to our esteemed guests and speakers of today's event. May I now request our respected Dr. Monica Kohli, ma'am, to felicitate our chief guest, Professor Sonia Nityanand, ma'am. Thank you so much, ma'am. Now,
देखो सब आ रहे होंगे
now I request Professor Dinesh Kausar sir to felicitate our guest of honor, Professor Abjeet Kaur, ma'am. Thank you, sir. Thank you, ma'am. I request all the dignitaries to come forward and felicitate our today's orator, Dr. Sangeeta Khanna, ma'am. It is a great pleasure that Dr. Yagnik's family is also here with us. I will request Yagnik madam and her daughter-in-law and granddaughter to please join us on the stage.
यही पता हम लोग जब जा रहे थे उसमें बैठ के आ रही थी तो कार में तो जब थी कहीं कौन जा रही लिपस्टिक ला रही क्या कुछ होगा
I request our esteemed dignitaries, Vice Chancellor and Pro-Vice Chancellor Ma'am to felicitate Sir. Sir is famous for his humble nature, hard work, dedication and clinical expertise. Thank you, sir, for being an amazing teacher and mentor. Your contribution to this institution will always be remembered with great fondness and respect. A round of applause for Dr. Dinesh Singh, sir, and everyone please give him a round. Now we move to a very special part of today's celebration. We have started a new tradition of award distribution to encourage our residents and staff to perform the best of their mark. Our department is proud to recognize excellence in teaching, patient care, and research. We will now proceed with the annual distribution of the awards. I request all the esteemed guests to come forward and present the award. The Best Senior Resident Award goes to Dr. Rishabh Garg.
ये सब सब
Throughout his residency, Dr. Rishabh has displayed a strong work ethics, demonstrating leadership qualities and inspiring his peers. The award for the best junior resident is being awarded to Dr. Akhilo Nair. Dr. Akhil's dedication to patient research, eagerness to enhance his knowledge, and willingness to go above and beyond make him stand out among his peers. The best anesthesia technician award goes to Mr. Yatin Pratap Singh. And the award for the best staff is given to Senior Head Clerk Mr. Sunil Kumar Kanadia and also to Dr. Rajesh Kumar Kanadia.
ये वाली वीडियो भी मेरे पास सेंड कर दे।
A big round of applause for all of them.
अरे राम मेरा ये तो प्रयास है।
Congratulations to all the awardees for showing their spirit and dedication. I now request respected Vice Chancellor Ma'am to address the gathering and share a few words of wisdom with us.
अच्छा मोनिका कॉलेज मैम सबको दिलवाए
Mr. Abjeet Kaur, Pro-Vice Chancellor. Dr. Sangeeta Khanna, who is the orator for today. Dr. Monica Kohli, who is the head of the department. Dr. Dinesh Kaushal, Dr. Tanmay Tiwari, Mrs. Kaushik and the entire family, their daughter-in-law and the daughter, unfortunately I don't know the names, but all of you, and all the esteemed faculty members in the audience. I can see a lot of surgeon colleagues here, So it just shows how important the anesthesia department is for them. And most important, the students, the residents, the junior residents, the senior residents,
and staff of the anesthesia department. First of all, a very many congratulations on this 64th Foundation Day of the Department of Anesthesia. So 64 years of the existence and progress of the department. I would like to congratulate the head of the department, Dr. Monica. She presented a very encouraging report of the progress of the department over the past 1 year. And it was interesting to note that lots of the faculty members of the department are also involved in various capacities in the growth and development, not just of the department but of the university as a whole. So that's a very good sign that the faculty members are actively working towards the growth of the university, because when the university grows, each and every department grows. I also would like to congratulate all the awardees. I cannot personally name all of you because I don't remember the names, but from the junior residents to the senior residents to the technicians and office staff, many congratulations that you have worked hard and got the award. It's also very encouraging to see the progress of the subspecialties of the anesthesia department in the report which was presented by the head of the department, from pain anesthesia, neuro anesthesia, cardiac anesthesia, as Dr. Abjit was saying, that every organ will probably get a dedicated anesthetist, but at least these are the difficult branches. And of course, the trauma ventilatory unit of the trauma center that is being handled very beautifully by the anesthesia department and led by Dr. Zia. So I'm very happy because now the complaints of an ICU support for the trauma patients is becoming less and less with the leadership role that Dr. Zia and this CMS trauma and MS trauma are exhibiting. And of course, Dr. Zia is a faculty of the Department of Anesthesia. So many branches of anesthesia are developing, subspecialties of anesthesia are developing under the umbrella of the Department of Anesthesia. Just shows that how much this field is advancing in today's era. So I would like to, I assure my support for the growth and development of these subspecialties. And as I told you, my dream is that you start a DM course in these subspecialties. Because now NMC allows broad specialities to start DM courses, provided they can show the complement of faculty to be different from that which is for the MD course. So I really wish that at least one or two DM courses can be started in the year to come, and we hear it in the next progress report of the department. I also am very, very happy to see Mrs. Yajnik here. It brings back old memories. You know, when I was a student here, Professor Yajnik was the head of the Department of Anesthesia, so it brings back a lot of memories of to me of my period when I was a student here. And it's so nice that you are here with your family, you know, with your granddaughter and daughter-in-law. And I remember because my own sister-in-law's father, Dr. Aapki, was very close to Dr. Yajnik, and I remember once every day, he, Dr. Garg from ophthalmology department, Dr. P.C. Dubey from surgery, and Dr. Aapki from pharmacology, and Dr. Yajnik from anesthesia used to meet together over a cup of coffee every day. after they took their rounds. That is the sweet culture of King George's Medical University, that we really feel, we're very friendly, we have a sweet culture here, and I think it has been maintained over years, because I've come back almost after 58 years and I still find the culture to be very sweet here. That should be maintained. So I wish the department many good wishes and hope that next year we get a similar high value progress report with some initiation of somebody, of course. Thank you and good wishes to everyone.
Thank you so much, ma'am, for your thoughtful words. It is my honor to invite Professor Tanmay Tiwari sir, the organizing secretary, to address the audience with vote of thanks.
Good morning, everyone. It is truly an honor to stand before you today and express my heartfelt gratitude for this special event. First and foremost, I extend my sincere thanks and gratitude to our Chief Guest, Honorable Vice Chancellor Professor Sonia Nityanan ma'am, for gracing this event and inspiring words with unwavering support for academic excellence to guide and motivate us. A special note of appreciation to our guest of honor, Pro Vice Chancellor Professor Abjeet Kaur ma'am, for her encouragement and valuable insights. Your presence here today even make the occasion much meaningful to us. I extend my heartfelt thanks to the family of Professor Yajnik sir for their extended support. You are thankfully welcome for the occasion of Professor S. Yajnik oration. I extend my deep gratitude to our today's orator, Dr. Sangeeta Khanna ma'am, who is the Senior Director at Vedanta Gurgaon and is going to speak on the topic Anesthesia for Robotic Surgery, the way forward, just after this program. I would also like to extend my sincere appreciation to the members of media and their presence to cover this event. Your role in sharing knowledge and spreading awareness is valuable, and we truly appreciate your support. A warm thank you to all the dignitaries, faculty members, students, and the members of the Department of Anesthesia for making this event a successful one. Last but not the least, a big thank you to all the surgical departments who have continued their unwavering support to the growth of anesthesia. Thank you and have a nice day.
Now I request everyone to kindly rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
For your valuable time. I would like to request esteemed dignitaries to step down the stage and join the gathering as we proceed further with today's oration. Now, I invite Dr. Aparna Shukla ma'am to say a few words about Professor Sudarshan Yajnik sir.
Thank you, Vanya. I am honored to present the CV of Professor Sudarshan Yajnik sir. He completed his Yajnik sir. He completed his MBBS at AD Medical College, Lucknow University in 1955. In 1957, he earned a diploma from Young Medical College, Bombay University. He also received diploma in anesthesia from London in 1965, and at the same year he attained the FSA RCS qualification from England. He worked as a full-time anesthetist at Lucknow from January 1958 to September 1961. From April 1962 to June 1963, he served as a senior house officer in anesthetics at Morrison Hospital in UK. He held the position of registrar in anesthetics at Thames HMC in London from May 1965 to September 1965. Following this, he was a full officer in anesthesiology at AIMS, New Delhi from December 1965 to 1966. In May 1966, he was appointed as an assistant professor at AIMS, New Delhi, where he remained until November 1973. He then became the professor and head at KGMC Lucknow, serving from 1973 until December 1992. In 2010, he received the Lifetime Achievement Award twice, one from Indian Society of Study of Pain and another from Indian Society of Anesthetists. He published over 40 papers and supervised about 20 postgraduate students on their thesis, mentoring many more during his 3-decade career. He also served as an external examiner for the postgraduates at various universities. He was not only an excellent teacher, but he also played an active role in various organizations. He served as the president of the Delhi ISA branch from 1972 to 1973, and he founded the UP State branch of ISA in 1974. Additionally, he was the member of Governing Council of ISA from 1976 to 1977. He also worked as an MCI inspector. Thank you so much.
Thank you, ma'am. We are now ready for one of the highlights of today's program, that is fourth Professor Sudarshan Yajnik oration. It is indeed a golden opportunity for each one of us to enrich and enlighten ourselves. Without further ado, let's dive into promising session marked for today's event. We are delighted to have with us Dr. Sangeeta Khanna ma'am, who will be delivering this year's oration on the topic Anesthesia for Robotic Surgery, the Way Forward. Again, I would like to invite Dr. Aparna Shukla ma'am to give a brief introduction of today's esteemed orator, Dr. Sangeeta Khanna.
Welcome, ma'am. Dr. Sangeeta Khanna ma'am is Senior Director and Clinical Head General Anesthesia at Vedanta, Gurgaon. She is past President of ISA Haryana, and she did her MBBS from Lady Hardin Medical College in 1992, followed by MD Anesthesiology from Maulana Azad Medical College. She has more than 30 years of work experience post-MD in leading hospitals. She was observer for lung transplant Toronto General Hospital and is the lead facilitator for the program in Vedanta, Gurgaon. She is a fellow of Indian College of Anesthesiologists and Airway Management Foundation. She has authored various chapters on robotic anesthesia. She is National Secretary for Hemodynamic Workshop, and she is examiner with the National Board of Examinations. She has mentored many students. I now invite Dr. Sangeeta Khanna ma'am to deliver Professor Yajnik oration.
चलिए यहीं पे हमको लगा चलिए नहीं
Good morning, all. And at the outset, I'd like to thank Dr. Monica for inviting me here today to deliver this Professor Yajnik oration. It is indeed a big honor for me standing here delivering this talk at KGMU. So today I have been asked to talk about the, anesthesia for robotic surgery. So before I start talking about that, I think let's look into a little bit about the history of how robotics started. It started way back, around the World War One and World War Two, when in the US, they thought that all the soldiers who were getting affected by the war and the war casualties, how is it possible to treat them? So they thought, okay, maybe the surgeon sitting in the US could sit over there and operate on all those war-torn soldiers. And similarly, so then NASA thought that, okay, if that is possible, then maybe the surgeon sitting in the US could also operate on all the astronauts who were not well, or who are on the moon, or who are in the space shuttle. And that is why NASA funded the whole program. But then what happened after that? Did it really go well? No, it was not so good. It was not possible for the surgeon to sit in the US and operate maybe on a soldier in Vietnam or somewhere far away, or maybe even on the astronauts in the space shuttle. So why did it not work out? It did not work out because obviously there was too much of a lag time. You did not have a team. It was not possible to give instructions to how to carry out those perform those surgeries. And obviously there were communication issues. So even after the initial development, there were quite a few years in between where nothing really happened and nothing worked on this technology. But since the technology was already there in place, so the first robot actually came up, 15 to 20 years later, in around 1985, when just one arm was developed that was known as the Puma 650, and this was only used to do neurosurgical biopsies. So it was avoiding a big craniotomy. You could, to do that biopsy, but with the help of this arm, a biopsy would be performed. And similarly, around the same time in UK, in the Imperial College London also developed one robot which was useful for doing just prostatectomies. So these were just, just the use of the technology, an arm which was being developed to do very specific procedures. It was not like a wholesome robot which was coming into play. But it was only in the year of around 2000, 1999 and 2000, when we had Intuitive Surgical actually developed the first surgical robot, and that was known as the Da Vinci robot. And this is the platform which is most commonly used, across the whole world. This is the platform on which most of the surgeries are being performed, and this was approved by the FDA in the year 2000. And that is when we have seen the surge of robotic surgery happening, usually after 2003 and 2004, when robotic surgery started working, and we had a lot of more procedures which could be performed by them. And now over the years, we have seen a lot of, as the advancements develop, we can see new systems coming up, like in the basic system was in 2003, we had the SI in 2009, and now we have the XI which has come up in 2004. So this is how we see the prototype, how it has changed over the years. In 1999 it was the standard, then we had the SHD, then the SI, and finally now what we have is the XI. And if we look at this prototype, we can see, the size is becoming more and more, more compact, so that it occupies less space in your OR. And then you can see the ergonomics also, you can see the arms which are now coming out at a horizontal level. Now you can see that they are coming out vertically from a bar at the top, so that it's easier to block the robot. It does not occupy too much space. There is no problem of the footplate of the robot hitting your OT table. So you see the changes, and I'm sure as more and more prototypes come up, it will become more and more compact and easier to use. And if you look at this robotic industry, we can see that by the beginning of 2023, there were more than 11 million robotic surgeries which have been performed worldwide by the Da Vinci robots. And there are more than 7,500 robots which already have been installed worldwide. And if there is such a big market, then obviously you will have other players also wanting to come and to play into it. So we now have Johnson & Johnson's, we have the Indian robot, the SS Mantra, the Medtronics, all of them wanting to make their robots, because obviously if there is a CAGR, growth rate, if they're expecting it to be around 30%, then none of the players would want to be far behind. You see that the market is going to grow at a rate of 15.7% with a $725 billion growth dollar industry. And hence we have, the Indian logo also in place. We have the SS Mantra, which we have, and Miganta also we have the SS Mantra, on which we are performing cardiac and thoracic surgeries. This is what it looks like. And if you see the visualization, again, it also gives you the 3D visualization and it's as good as the international or the Da Vinci platforms that are available. So what are the advantages of the robo? The advantages are obviously it gives you a 3D magnified image. It filters the hand tremors of the surgeon. It is a minimally invasive surgery like any laparoscopic surgery. There is less blood loss, less pain, early amputation, and also it has been found that there is better cancer-specific survival with the robotic or any minimally invasive surgery. And it is possible to operate in areas where you generally it's difficult to reach. For example, in the urogynecology procedures deep down into the pelvis, your lymph node clearances are much better. Or similarly, when you're doing a thoracic surgery, when you're talking deep down into the neck, the areas around the cervical lymph nodes, or when you're the brachiocephalic trunk, that is involved. So all those areas which are difficult to reach, it is much easier to reach with the robo. And it had, if you look at the instruments, they have 7 degrees of freedom. That is, you have 3 translational, 3 rotational, and 1 grasping movement. And what does the robot look like? This is what it looks like. Basically, what it does is it teleports the surgeon into the operative field. The surgeon can sit at a console far away from the operating table. So you have a surgical console, you have a patient cart, and you have a vision cart. The patient cart is the one which docks the robot close to the operating table, and you have a vision cart on which you have your 3D monitor. It has your insufflator, it has all the recording devices, and this is the assistant as well as the staff assistant can see what is going on. So what are the challenges that it has brought to us? It has brought us new opportunities to learn and adapt. It is pushing boundaries of our understanding of the human physiology because we are always operating in extremes of position. It is helping to guide, form protocols and institutional guidelines, developing a culture of teamwork. And if it is the future, and now today, if the patient is also asked, comes and tells, I only want robotic surgery, I don't want anything else. So there is no way that we can deny that it's not available or, we cannot provide it. So if it is there, then we may as well adapt to it and learn about it. So what does an OR setup, when you have a robot really looks like? You can see that you will have your anesthesia with an anesthetist standing at the head end. You will have a vision cart, you have a patient cart, a surgical console which is away from the operating table, and a slave monitor where the anesthetist, the OT assistant, the scrub nurse, all of them can see that what is going on. So the surgeon console is positioned a distance away from the operating table, which enables the surgeon to manipulate the surgical instruments and the camera. You can also have dual consoles these days, which help in teaching. You have a trained surgical assistant who is present at the table. He is the one who is going to deploy the robotic arms. And he is also the one who is going to insert and remove the instruments and do the suctioning or whatever, if there is bleeding, the cautery or whatever that is needed. And you have a scrub nurse who is going to assist the surgical assistant. The purpose of the vision cart is to provide reliable and intuitive control over the instruments and deliver immersive 3D visualization. So if you look at a team, what is the robotic team that will consist of? A robotic team will consist of an anesthetist who is responsible for the anesthesia. If it's a thoracic surgery, then basically do the lung isolation and positioning. You have an assistant who is supporting the anesthetist. You have an operating theater assistant who will initially support the anesthetist, and afterwards he will take care of the robot, move the robot, dock it, and help in positioning. You have a lead surgeon who is going to be sitting at the console, and surgical assistant who is there at the side of the table for the instruments. A scrub nurse who will be providing it, and one additional floor nurse who will be or maybe help, suddenly a catastrophe occurs, you have to convert to open, you need something, so you will have a floor nurse for that. So when we look about anesthesia considerations, if you just Google it or when you put what are the anesthesia considerations, this is the response you get within 0.3 seconds. So let us see what are these anesthetic considerations that we will be talking about. The anesthesia considerations are based on 4 important pillars. One is that we have to keep our basics right and prepare our patients well. Consideration of laparoscopy and CO2 insufflation has to be kept in mind. The extremes of position, whatever surgery we do, it involves extremes of patient positioning, and that is the most important thing when we are doing robotic surgery, because that is the only thing that is going to ensure good outcomes and prevent any injuries, and vigilance and proactive care. So let's see from the basics, what is the evaluation? Evaluation is a routine workup as you do for any other case that you would like for that patient, whether it is open or lap surgery. Evaluate them and optimize the comorbidities. Any further investigations like echo, cardiac workup will depend on what the patient's comorbidities are, and you can work them accordingly. A few relative contraindications. Today there is no absolute contraindication that is there. But a few relative contraindications would be like a patient who's had a recent ocular pathology like glaucoma or cataract surgery, or if he has some kind of a spinal pathology, because your positioning is going to be such that it is always going to ask for a break either at the thoracic level or at the lumbar level. So you have to rule out any spinal pathology the patient may have. History of any raised ICT or intracranial surgeries. Diaphragmatic eventuations or high-chest hernias. Poor cardiac function is one of the most limiting factors that would contradict your robotic surgeries. And any bullous disease of the lung, ILD. And always take a consent for conversion to open whenever you are taking a patient up for surgery. In the OT preparation, you obviously should always have a team ready in place, because that is the team which is going to help you in positioning your patient. At least we prefer to have two wide-bore functioning IV cannula rather than having one cannula to which a multi-port connector is there, because your hands are going to be away from you. So if there is any extravasation, you will not come to know. So it's always better to have two IV cannulas in two separate hands. Invasive lines depend on the need of the patient. When we started in 2009 or 10, when we first started doing our robotic surgeries, we were even putting a central line, because obviously it was a new procedure, the steam tremendous, we were not sure how long the surgeon would take, we didn't know how the hemodynamics were going to be affected, right? So I think in the initial 10 to 15 patients, we had a central line in all our patients. But now over the years, gradually we learned that it's not really needed, unless if the patient demands for it. Otherwise, we don't really need a central venous line. Two good cannulas enough. Arterial line is generally required in most of the patients, but if it's a young patient who's coming for an atherectomy or something like that, then you can do away with it. It's very difficult to do. An OR-compatible table with the procedure, because we have to give a break sometimes at the lumbar level, sometimes at the thoracic level, sometimes towards steep, towards low. So you have to ensure that your OR table is also compatible with the procedure. And once the robo is docked, remote has to be off. In fact, you have to just throw your remote away, because there has to be no movement of the OR table once the robo has been docked. There has to be no movement. The OT table should not move once the robo gets docked. A forced air patient warming system, because it's a long procedure. And for positioning, there are multiple things which are available. Depends on what you have or what can be made available. You will need a lithotomy pole. You will need bean bags, gantries, leukoplast, egg crates, anti-skin mattresses. So all that depends on whatever is available or whatever is going to be procured. Can you access the patient? Really no. You cannot know within the robotic arms where the patient is. You actually cannot identify where your patient gets lost. Coming to the intra-op monitoring, it is obviously a standard ASA monitoring. The routine monitoring that you use should be used. Ideally, take all your ECG electrodes, because if they come off, you may various positions that may be involved. You have, the steep remember position, the modified Z position. When you're doing a thymectomy, it would be a supine with your hand low. It could be an arm abducted on the side. It could be a lateral position, depending with a break at the thoracic level or at the lumbar level, if it's a lobectomy or if it's a nephrectomy. So there are multitude of positions which get involved in these cases. I'll talk about the most common one which we use for all our urogynecological procedures, that is the steep Trendelenburg position. It has to be standardized for each surgery. For the steep Trendelenburg position, you can use straps, shoulder braces, non-sliding mattresses, or a custom-made headrest. The risk of brachial plexus injury is high because of the excessive quadrant pressure exerted by the strap against a virtually unsupported head. And the weight of the head also causes a lot of cervical head strain. Always avoid direct contact or pressure of the arms and hands against the leg holders which are there by placing additional padding. And elbow padding has to be done with the thumbs positioned neutrally. A low lithotomy is what is preferred. Strap your leukoplast in a figure of 8 fashion over a Gamzee pad and fold and make an extra cushion over the shoulder. Upper end of the strap should be at the angle of the shoulder, where the lower end is above the postural margin. How tight or how loose it should be, you can just pass one hand below it. That is what we see. If you can pass just one hand below the thing, we know that it's neither nor tight nor too loose. You have to take care of the limbs. It's always a low lithotomy and with mild flexion at the hip. And the hands and fingers should be covered and positioned with the palms facing medially. What can you use? You can use gel mat, you can use x-rays, you can use bean bags, you can use head support, whatever, shoulder braces, whatever is available, all of them can be used for positioning. The midpoint of the shaft of the table should correspond with the umbilicus, because this is the only way that you can get a maximum head down. Otherwise, it is not possible to give a complete head down, because your head portion is going to hit with the foot plate of the OT table. Any problems with Steve Trendelenburg? Not really. It has been used, Steve Trendelenburg has not been associated with post-operative complications, and hence it can be considered safe with regard to any risk of thromboembolism, cardiac or cerebrovascular complications. But proper individualized preventive measures, you have to take care of each individual patient and strap or position them accordingly. Each patient will have different requirements. That is what we have to keep in mind. You have another position, like some patients you may not want to give a Steve Trendelenburg, for example, a patient who has COPD or a patient who has had a recent intracranial surgery or somebody who has a controlled glaucoma. For them, you don't want to give that Steve Trendelenburg position. Initially, there were like absolute contraindications for not accepting these patients for surgery, but these days we have started accepting those kind of patients if it's a well-controlled glaucoma, or if they have had surgery, neurosurgery, but he is well controlled and is asymptomatic. But in these patients, you do not want the IOP or the ICP to rise. So you have a modified Trendelenburg position, and what you do in these patients, obviously it's not recommended in patients with spinal pathology, is you do a 15 to 20 degrees reverse Trendelenburg, but you give a little bit of break at the thoracic level. So in this way, your ICP and IOP does not rise as much as it would rise in a Steve Trendelenburg position. So we did a study, and we found that, using this modified Trendelenburg position, the increase, it had a better neuroocular safety, because the IOP was less as compared to a patient who had undergone the same kind of surgery in the Steve Trendelenburg position. Similarly, you may have to position in the lateral also. So for the lateral also, you have to take care that you place an axillary roll under the axilla to prevent any brachial plexus injury, and the upper non-dependent arm also is placed, over a lot of rolls or bed sheets, so that the radial nerve does not get compressed. The second important thing is to prevent injury. The most common injury obviously is your neuropraxias. You have done a beautiful surgery, but in the post-op the patient comes and tells you that I have difficulty in walking or weakness in my limb, then it really does not help you. So I think neuropraxia is the most common problem that the patients will tell you about in the post-op. There may be some tingling or numbness maybe in the upper limb or lower limb. So that is the injury which we want to prevent, and that is only possible when you have a team dedicatedly doing this, because this is not the responsibility of the anesthesia technician or the assistant. It's a teamwork, and the surgeon, the anesthetist and the technician, all of them should be involved when the position of the patient is being made. And it should always be done with close coordination with the surgeons, requiring a high level of vigilance. And we have to do frequent checks and rechecks. You will put the table down in the head, look, see that there is no snagging or lines, your circuit, all of them are free. None of the wires are getting entangled in the table. So do all that before you actually hand over your patient to the surgeon. Why do we need to do this? You have seen all these complications happening. You have the robotic camera, and that will hit, because of a sudden movement, it hits on the nose of the patient. You have the secretions which are coming out, and that is why, I have really stressed on the fact that do adequate good corneal padding, not just a plain dressing, do a good orogastric suction, see that you have emptied the stomach, check that you have put adequate padding on the nose, especially if the 30-degree down camera is being used. And keep checking the face regularly in between, every hour, to see that, no damage is happening. So these are the possible injuries that are possible, brachial plexus or the lower limb. You can have the peroneal nerve or being compressed, or the posterior tibial nerve, the upper limb, the face, as well as the peripheral nerves, all have to be taken care of. Again, change the position of the head every hour or so, because you can have ring alopecia, you can have a small kind of a subdural hematoma or a collection because of the prolonged pressure that is there. The venous congestion can cause a collection. So all these, we have actually encountered these problems over the years, and that is why, it's important to keep having these guidelines and protocols or a checklist that you keep doing these things and checking them periodically. The other thing is about the pressures and perfusions. We all know, obviously, there is a pneumoperitoneum because you are going to use CO2. It's like any other laparoscopic surgery. So to prevent that sudden drop in blood pressure which will occur when you start your CO2 and create a pneumoperitoneum, before that, just slightly fluid load your patient, till the patient to a slight head down position before starting your peritoneal insufflation. Prevent pooling of blood with the use of sequential pneumatic compression devices, and wrap your legs with the elastic bandages. And this will prevent the sudden drop in blood pressure that can occur. And at the time of closed port placement is the only time when you will allow a pressure of 20 millimeters of mercury. After that, the surgery can easily be performed between 12 to 15, although the surgeon will always say, I cannot see and I want the pressure to be 18 and 20. But generally, you have to put your foot down and you can say, okay, 12 to 15 is what is going to be maximum you allow. 20 can be allowed for a short period of time, especially when there is bleeding around the prostatic venous plexuses. So at that point of time, you may allow it to go about the insufflating pressures. There you can keep your transducer. When you are using an arterial line, the transducer will have to be kept at the level of the carotid artery or the external artery. The displayed arterial pressure may overestimate the arterial pressure at the level of the heart. And NIBT always has to be there so that it can match with your invasive arterial bleeding. So, your invasive arterial pressure. So both the pressures have to be monitored regularly. The other respiratory concerns which we need to take care of is there is a capillary migration of the carina related to the vocal cords, and this will cause a shortening of the trachea by 0.4 to 0.2 centimeters, and it can result in unintentional endobronchial intubation. So if there is a sudden increase in the airway pressure, always auscultate and check that the tube has not migrated, other than moving of the obvious causes of increasing your airway pressures. Then, because of the CO2, you have to increase your minute ventilation by 25 to 30% to maintain your normocarbia, because the absorption will be influenced by the partial pressure gradient between the cavity and blood, the diffusion coefficient, the surface area of the cavity, and the perfusion walls of the cavity. So another important thing which we all need to keep in mind is when we started doing our robotic surgery, obviously when you are using a pneumoperitoneum and going head low, your peak airway pressures are always going to increase. So we were very worried, and in fact when we started our surgery, there were a few cases which we did the Steve Trendelenburg and put them in the head low, and we said no, I don't think we can operate on this patient. I think we have to convert into open, because the patient developed such high airway pressures that it was not possible to maintain them. But over a period of time, we realized that we really do not have to be worried about these peak airway pressures. Because why are we worried about these airway pressures is because we think that the alveoli are going to rupture if we have such high airway pressures. But the important thing which we have to keep in mind is not that the high airway pressure, it is this transmural pressure. And what is the transmural pressure? The transmural pressure is the difference between an intracavitary and an extracavitary pressure. So when you place the patient in the head low position, it is both your alveolar pressure as well as the intrathoracic pressure which is increasing. So your transmural pressure is constant. Your transmural pressure is not increasing. So whether your patient is in supine or in head low, the transmural pressure remains the same. So if the transmural pressure remains the same, the risk of alveolar rupture does not arise. And hence, we do not have to be really overtly scared of your high airway pressures that we have achieved. And in fact, we can operate on these patients if they have, it's the plateau pressure which we can keep in mind rather than actually looking at the high airway pressures. Because if you see, these are the patients who are actually going to, who are the patients who really benefit from robotic surgery. There are patients who are not fit for an open surgery. So there are patients like obese patients, They are the ones who actually benefit from a robotic surgery. The healing, the scar, everything is much better. Your post-op recovery. And these obese patients are the ones who are going to give you the problems. So if we start diffusing them, then there is no point of doing a robotic surgery. A patient otherwise is not going to benefit. So all these things, when you keep doing it, and keep evolving, you realize that these high level pressures are not really something that we should be too much worried about, and we can accept these patients for robotic surgery. The other important pressures are our cerebral perfusion and ocular perfusion pressure. And in this, what we need to know is we have to measure the effective perfusion pressure. So what is the effective perfusion pressure? The effective perfusion pressure is the difference between your MAP and that chamber pressure. And because a patient is going to need head low, both your ICP and IOP is going to be high. So if both of them are high, your effective perfusion pressure is going to go down. And that is why you normally we are happy with a mean of 55 to 60. But in these patients, ideally it is always better to target a higher map because your effective perfusion pressure is going to go down. So target a map of maybe 70 to 75 so that your effective perfusion pressure is at least maintained in the range of 50 to 55 because that is where your auto-regulation is going to work the best. So if you want to really measure, obviously there is no way to measure it, but with the advent of ultrasound, looking at the optic nerve sheath diameter, it can give, it's a surrogate marker of your ICP. So you can measure it with the help of the ultrasound probe. You put it, on the eyeball and measure it at a 0.3 millimeters beyond and look at the cross-sectional diameter. Normally it's around 0.4 to 0.5 centimeters. And if it increases, from 5 to 5.7 millimeters, we know that the ICP is above 20. So it's just a surrogate marker of how high your ICP is going. And if you have such things or you see that diameter is increasing, then use of propofol or hyperventilation, all those techniques can be applied and you can reduce your IOP or ICP. And what we found was that the diameter actually went on increasing as the time of steep trembling increased from 30 to 60 to 90 to 120 minutes. But the good thing was that the moment you made the patient flat, it comes back to normal. So it's not something to be worried about, but yes, if a patient who has glaucoma or a recent surgery, then maybe it's a useful guide or tool to tell us, how much the ICP may be. Because posterior ischemic optic neuropathy is the most dreaded complication, and that is why it's important that, we do not have any hypotension and we maintain a good effective perfusion pressure. Another dreaded complication is your well-leg compartment syndrome. Because the lower limbs are the least perfused area during STC. And if you see that if the perfusion is compromised, the effect is quite similar to applying a tourniquet. So the effect is quite similar to applying a tourniquet, and if the limb remains ischemic for long, then it can result in reperfusion injury. And then finally, the last pillar is your fluid management. So to avoid any hypotension, avoid excessive fasting before surgery. Clear fluids can be given 2 hours prior to surgery and maintain normal volume. Initially, what we were doing was we were following a fluid restriction. But now fluid restriction is not required. You can, you don't have to be liberal with your fluids, but you can generally give them fluids at a maintenance dose. And colloids can be given to avoid the edema that is there. And if there is hypotension, avoid excessive depth of anesthesia and maintain normal cardiac contraction. For reversal and extubation, all the patients can be extubated. If there is periorbital edema, then there may be airway edema, so that should be kept in mind. So use a nasopharyngeal airway post-extubation. Always do a cuff leak test before you extubate your patients. And use of faster offset inhalational agents like desflurane or sevoflurane. And pain generally is not much because it's a minimally invasive technique. So you can use the newer ultrasound guided blocks, but otherwise nothing much is required. A multimodal analgesia plan can be placed. And if you are doing too many of these surgeries, then always have an unlocking drill. You should be able to unlock the robot within 30 seconds to 1 minute if any catastrophe occurs. So how do you do the cuff leak test? There are two ways on how which you can do it. One is you can deflate the ET cuff and check whether air leaks around the tube is there after giving a sustained pressure of around 15 centimeters. Or you can make the patient breathe spontaneously and then occlude the proximal end of the ET after cuff deflation, and ideally the patient should be able to breathe around the tube. So now, after talking of the conventional urogynec procedures, let's talk about some unconventional robotic surgeries. We were the first to do the robotic renal transplant also. We were quite skeptical to do it because obviously we know that the laparoscopy and the insufflation is going to, have a negative effect on the GFR. We've all read that. So in such cases, you will always keep your intra-abdominal pressure less than 10 after the vascular anastomosis has been done. And then secondly, it was a surgery where, you ideally give a lot of fluids when you do kidney transplant. But here we could not give too much of fluids. So you give your fluids after the anastomosis is done and once the patient is made in the header position. The advantage was there was much better pain relief, obviously, because it was minimally invasive. So there was no need to give any paravertebral or epidural catheter. And you could just use your simple IV analgesics and take care of the pain. Then coming to robotic assisted thoracic surgery, which we do a lot. It can be done as a multiport or as a unimodal, whatever, depending on the kind of surgery that needs to be done. A lot of mediastinal masses are being done by robotic assisted thoracic surgery, thymectomies for myasthenia or non-myasthenia indications. In myasthenia, obviously, we have to take care of, have a good detailed history regarding the bulbar involvement, whether the patient had immunotherapy or myasthenia crisis. We take care of his current medications, see what were the last doses that he had, and also interrupt those medications to the nasogastric tube and do a neuromuscular monitoring. The device that you will use, ideally, it always has to be a DLT, because if the blocker, it can be misplaced and you cannot reach the patient. So DLT is always preferred. And if there is no specific guide, then left DLT is always preferred over the right, because obviously it's easier to place and does not get displaced easily. And always keep doing a fiber optic bronchoscopy after you have placed the tube and also after patient. Monitoring, you will always use a neuromuscular monitor. The electrodes can be placed depending on kind of and you have to place, actually have to hands below the level of the chest, because that is where the arms are closed. So patient presses into for the victory, you have to put a break at the thoracic level, so you put our shoulder axillary load to the thorax. This is another position which can be used for thymectomy, where the leg is turned on the opposite side and really approaching from this side. The protective lung strategy, you all know, has to be used. You are always remember to use your infusion and over before you start with your protective lung strategy if you want to prevent any desaturation or blocking of the ensure that your insufflator pressures are kept at, set at less than 10 when you start a thoracic case. Because there are times it has happened that when insufflator pressures were kept at the abdominal settings at 15 and 20. So if at such a high rate the CAT gets developed, then I really there is a chance of pneumothorax happening. Because in thoracic cases, you do not want the intrathoracic pressure to be more than 5 to maybe let's prominent in patients who are poor in the function of hypovolemia, and hypercapnia can also be challenging to manage during one lung ventilation. And also the instruments that they are using.
है ना, आने में टाइम लगेगा 8वें फ्लोर तक। आओ तब तक इधर आते हैं। यूं क्लास कब चलती है? हमारे बाल भी बहुत बुजुर्ग हो गए, क्या करें। कहाँ से करवाए? आ जाओ नीचे चलते हैं। ऐसा कॉन्फ्रेंस तो